All right, so we are going to continue on with our HOPS assessment. So we went over our history questions, what you should be asking during evaluation, and then we went over observations, what are you looking for? And then the next step is going to be your palpation component. So palpation is just another way of saying feeling. So when I am going through my evaluation process, I'm first starting with my history questions, communicating with my patient, asking those detailed questions, looking to see if there's any, deformity, swelling, that sort of thing. And then I'm going to start actually touching whatever area it is that they might say is hurt or injured. And that's going to allow me to kind of figure out if there is a difference between the uninjured side versus the injured side. Because your sense of touch is obviously going to help you too to feel if there's maybe more swelling, heat, inflammation, all of those signs that we've talked about previously. When you are palpating, you are going to be palpating as much of the anatomy as you can. You're obviously feeling for the different parts of the body. That's where understanding the anatomy of the foot and ankle is going to be important because you're obviously touching the area. And if you're understanding what is in that structure, then if there's swelling over that structure, that can help you to indicate whether or not maybe that part is damaged. And then you might also be feeling too for crepitus. So crepitus is a term that I will use throughout the year. Crepitus is just that crunchy sound that you might hear. So oftentimes people will ask me, my knees crack, my ankles crack. That is crepitus. Or it could be too that maybe if you feel like crunchiness in your shoulder, maybe you had a previous knot in your shoulder, that crunchiness, just know that's called crepitus. And also, if you are someone that has cracky joints, as long as it's not bothering you, I wouldn't worry about it. And then you're making sure too if the joints are aligned. So that's where you're comparing the uninjured side to the injured side. Again, you're checking for that swelling. Are there areas that are painful? Does it look like the person might have inflammation going on? Is there heat, redness, etc.? And then you're also looking to see, is there a deficit in the muscle versus or the tendon? And what that means is, does it look like maybe the muscle on the injured side is bigger than the other one or smaller? Does it look like it's not as strong as the other side? So again, you're just comparing the uninjured side to the injured side at this point. You then go into your range of motion. So I'm actually going to skip parts of this, but we will be going through this part right now just because it is something that you will need to know for this chapter. So within your range of motion, if you don't know already, is just determining how much your joint can move in a given direction. So your joints have, ways that they're supposed to move. If you notice that the uninjured side has more range of motion, so it's able to move more than the injured side, then that can indicate that there's, probably something going on. So it's just a good indicator. And if you plan on working in like physical therapy or in a clinical setting, maybe at a sports medicine clinic or even Division I college, they will use goniometers, and that's what this fancy little ruler thing is. It's just one way that you can check range of motion with a tool. I don't use it in my training room just because I don't see students consistently, so it's somewhat unnecessary. But if you are seeing someone consistently, you have a patient that's coming in weekly or every other day, so forth, you would probably want to use one of these tools just to see if they're actually improving. You have three major types of range of motion. So you have your active range of motion. That is when the patient is actually doing the movement on their own. So maybe it's you asking them, can you bring your foot back? Can you point your foot downward? Your passive range of motion is when the patient is going to be relaxed and you're actually moving them through that range of motion. So oftentimes if somebody is injured, I'll ask them to actively perform their range of motion, and then I will then passively perform their range of motion and ask if there's a difference in the two. Because if they have pain when they're actively doing it, but no pain when I'm doing it, then it could indicate that maybe they're having some type of muscular issue, etc. And then the last thing would be your resisted range of motion. So this is where I ask someone, okay, I want you to try to bring your foot up, but while you're bringing your foot up, I'm going to be resisting you doing so. And so that's going to allow you to see if there is any strength deficits versus the injured side and the uninjured side. And so, yep, this is just kind of the definition. So your active range of motion, just make sure you have this written down. Passive range of motion, again, is when you are performing the range of motion, and then your resisted range of motion is when you are actually using resistance as they're performing their active range of motion. So why is it important that we perform bilaterally on the uninjured side first? So the biggest reason is going to be that you're wanting to compare what your patient's baseline is. And so some people might be stronger than others. Some people might have more range of motion than others. Some people might have more like flexibility than others. So again, you're wanting to get your patient's baseline and then determine it off of that. And again, so it just allows you to look at what is normal for that athlete. So you can have athletes that, maybe they have terrible range of motion. And for somebody who has normal range of motion, that would indicate that maybe they're injured, but it could be that they just don't have any flexibility. So it could also indicate there is nothing going on. So that's why it's important to compare their baseline. When we're talking about the foot, you have range of motion at each joint. So just remember each little segment of your toes have a name. So your distal phalange or phalanx. And in between that, you have a joint, and then that's where you have ranges of motion. So like in each little one, your ability to curl your toes, that's going to be range of motion. Your ability to straighten your toes, that's going to be range of motion as well. As for your ankle, you have movement at the subtalar and subtalocrural joints. So remember, the subtalar joint is where that movement is occurring between the calcaneus and your talus. And then the talocrural joint is that movement between your tibia, fibula, and talus. And so you're basically assessing all of those in just one movement. And again, foot and ankle act together during movement. Toes are assessed together as well. So it's very difficult. You can try it now, but your toes pretty much work together. It's really hard to isolate one toe and have it maybe straighten. Your big toe, that's easier. But if we're talking about phalanges 2 through 5, it's going to be really difficult to have them try to do something different than their other toes are not. And then this is just important for you to know. So ankle movements, we've talked about dorsiflexion and plantar flexion. Do not forget what those mean. So dorsiflexion is when you're bringing your foot back. Plantar flexion is when you're bringing your foot down or pressing down on the gas pedal. Inversion is when you're bringing your heel and your toes inward. And then eversion would be when you're bringing your heel and your toes outward. So that movement of lateral movement with your foot, and then eversion would be that everted movement. When it comes to toe movements, like I said, you have flexion at your toe joints or your dips and your pips. And then you also have that ability to straighten them, which would be extension. You also have the ability to spread your toes and bring them together. So if you're spreading them apart, that would be abduction. And then adduction would be bringing your toes together. All right, I'm going to skip through the rest of the range of motion. We will be eventually getting to the special test, which will be the last part of HOPS assessment, but I do want to go over injuries before we get into that so that the special tests make more sense. So I'm just going to skip through some slides, and then we'll just start talking about a couple injuries related to the foot and ankle. Okay, so foot and ankle injuries. This clearly is a fracture because your foot should not be completely turned around. But anyways, we'll talk about some structural deformities of the foot, and then we will leave off of that today. So you have different types of foot malalignments. So what that means is when you're standing, you should have a little bit of an arch, but you can have where you have extremes to that. So it can be where somebody is flat-footed, where when they stand, it doesn't look like they have an arch, or it might be very small. And that is called pes planus. So what that means is their arch can be really rigid, or it can mean that their foot is really flexible. It's going to depend on the person. But typically people who are flat-footed will have issues with like maintaining their arch, obviously. And then that arch, if you remember, is intended to support your body when it comes to like impact. So when you're standing, jumping, running. So people with flat feet tend to have issues with like shin splints or knee issues, sometimes hip issues. And that's just because the part of their body that's intended to support that impact, it's not that it doesn't exist, but it's just weaker than maybe somebody who doesn't have flat feet. And there are ways to, kind of correct that. You can get inserts for your shoes, so it's not something that is a serious thing, but I mean, it can be if it's left untreated, or if you do have issues. Then you have other extreme to that. That's going to be pes cavus. So that is called hollow foot. And so it says it's congenital, which means this is something that can happen obviously when you're born. You're not able to also effectively absorb the ground forces. And so you can also have issues with that as well. So I've never been diagnosed with pes cavus, but I do have very high arched feet. And so for me, I don't get shin splints. So shin splints oftentimes happen to people who are flat footed, and that's on the inside of your shin. So that's your medial shin area or tibial area. I have opposite of that. So I end up having like lateral pain on my lower leg. And that too is just because my body isn't able to absorb forces correctly. So these are just some examples. So this would be flat foot. And then this would be your more high arched feet, which would be pes cavus and pes planus. You can also have malalignments in your toes. So if you have a malalignment in your toe at the dip joint, so the dip is the furthest part away from your body, so that's your distal phalanx. That is called mallet toe. So basically, that joint is just stuck in flexion. And then you can have also where you have a joint stuck in flexion, but instead of it being the dip joint, it's going to be your pip joint. So both of these can cause issues when it comes to like running. You can have a lot of pain at the toe joint. There was a girl when I was in high school who I was friends with, and she actually had surgery where they stuck rods in her toes because she was suffering from such severe pain due to the foot malalignment. But again, sometimes just footwear, taping, things like that can help to treat it if you're not wanting to have surgery. All right, we will stop there for today. We will go over the remaining injuries in the next few days, and then we'll eventually get back to the HOPS assessment covering the special test. So just make sure you're turning in your notes by the end of the period, and I will see you guys tomorrow.